8. Start. So good morning, everyone. Welcome to today's journal club. So first article will be on development and adaptive function in individuals with SCN2A related disorders. Myself, Dr. Lakshmi. I'm a third year resident, and I'll be presenting under the under Dr. Ajith sir. So coming to SCN2A related disorders or SRDs. So SCN2A gene encodes the sodium voltage gated sodium channel, that is 1.2, crucial for neuronal excitability and action potential propagation. So mutation in SCN2A has been associated with a spectrum of epilepsies and neurodevelopmental disorders, which is highly heterogeneous, manifesting in a variety of unique diagnoses, including self-limited familial and non-familial infantile epilepsy, that is SELFNI. Previously, it is called the benign familial infantile seizures, and epileptic encephalopathies, ataxias, autism spectrum disorder, intellectual disability, and schizophrenia. So now coming to the structure of voltage-gated sodium channel. So it's a large transmembrane protein complex that plays a critical role in generating and propagating action potentials in excitable cells like neurons and muscle fibers. So SCN2A encodes for the alpha subunit, which is a single large fiber polypeptide. So it's a single large polypeptide made up of 4 homologous domains labeled D1 to D4. And each domain consists of 6 transmembrane segments. And this structure also contains beta subunits, which are smaller accessory proteins that modulate the channel kinetics, surface expression, and cellular location. Now coming to the pathogenic variants of SCN2A. So the gain of function mutation causes increased sodium channel activity, causing neuronal hyperexcitability, which results in an early onset phenotype. Whereas a loss of function mutation causes reduced activity of the sodium channel, resulting in neuronal hypoexcitability and late onset phenotype. So this table from Wolf et al., which got published in Brain 2017, beautifully summarizes the genetic and the phenotypic spectrum of SCN2A related disorders and how it relates to treatment response. So the cohort can be, so they have divided the cohort broadly into group 1, which is early onset, and so the cohort is being broadly divided into 3 major groups based on epilepsy onset and the mutation types. So group 1 includes individuals with early onset epilepsy beginning before 3 months of age. And these cases are mostly caused by the missense gain of function mutation, which leads to increased sodium channel activity. So clinically, they present with early onset encephalopathies such as Ohtahara syndrome, and or epilepsy of infancy with migrating focal seizures. So importantly, they often show a good response to sodium channel blockers like phenytoin or carbamazepine, as these help counteract the channel overactivity. And they all so group 2 is the late onset, that is onset after 3 months of age. So these cases are mostly caused by the truncations or splice site mutations, that is loss of function mutations. And group 3 is the non-epileptic, that is presenting as ID or ASD alone, mostly having the truncating loss of function mutation. So the group 2, that is late onset. So late onset epilepsy group has seizures starting after 3 months. So they are typically due to the loss of function variant and usually presents as the LGS, that is Lennox-Gastaut or West syndrome. And they show poor response to sodium channel blockers. As well as group 3. So they includes non-epileptic individuals, mainly presenting as intellectual disability or autism spectrum disorder. So they also have poor response to sodium channel blockers. So with this brief background, we'll go to the aim of our study. So that is to delineate developmental and functional abilities in individuals with SCN2A related disorders using phenotypic subgrouping functional classification system and VAPS-3, that is Vinland Adaptive Behavior Scales, to improve the prognostic clarity and guide clinical trial design. So it is a mixed retrospective cross-sectional study, and the participants were recruited from SCN2A Natural History Study, Murdoch's Children's Research Institute, Melbourne, Australia, also from University of Melbourne Epilepsy Genetic Research Program, and the global recruitment of individuals with neurologic or neurodevelopmental disorders due to pathogenic or likely pathogenic SCN2A variant. So they have included participants with intragenic SCN2A variants, and they have categorized into early onset and late onset phenotypic groups. Rather than a biophysical mechanism, that is gain of function or a loss of function. So the phenotypic classification include early onset phenotype, late onset, and the CNV phenotype. In the early onset, the seizure onset start before 3 months or onset between 3 to 24 months with normal development or no epileptic spasms. This is broad classification. And late onset phenotype, all other individuals, including those with intellectual disability or autism spectrum disorder without epilepsy, were also included. And participants with SCN2A containing 2Q24.3 copy number variants often include additional sodium channel genes, so SCN1A and SCN3A. So these genes forms a cluster in cluster at the 2Q24.3 locus. Hence, that was phenotypically classified under a separate group. And the data were collected on the details and the inheritance pattern of SCN2A, age, sex, epilepsy phenotype, and the presence of ASD diagnosis were made, and the developmental history was taken. So they have used the functional assessment tool, which include the gross motor function classification system, which assessed the motor function mobility. And they have levels that is 1 to 5, meaning level 1 means the child could walk independently. Level 5 means transported in wheelchair. So next is the manual ability classification system, where they have tested for the hand use or the fine motor function. And level 1 means handles easily. 5 means no effective handling. And communication function system classification system, which assess the everyday communication ability. That means level 1 means child could communicate effectively with all. 5 means rarely effective. And the next domain was the eating and the drinking ability classification system, where they assessed the feeding and the swallowing ability. And level 1 means the child could eat safely, and level 5 means unsafe or non-oral feeding. And adaptive behavioral composite have been assessed. So that is an overall summary score derived from the VAPS third edition score, that is Vinland Adaptive Behavioral Scales, which gives a global measure of an individual's everyday functional abilities. And the domains included were communication, daily living skills, socialization, and the motor skills. And they have further subgrouped the cohort into an early onset benign, which include the Selny phenotype. That means typical developmental outcome with no neurological symptoms after 2 years of age. And early onset intermediate, which is the ongoing neurological or neurodevelopmental symptoms after the age 2 years. And at least one of the following, that is persistent seizure or a movement disorder like episodic ataxia, or developmental delay or intellectual disability up to moderate severity, and early onset severe, which is severe to profound developmental impairment. And they have divided the late onset phenotypes into individuals with seizure and those without. And the data was analyzed at the whole cohort level, then phenotypic group level, that is early onset, late onset, and the copy number variant groups. And the missing values were excluded from analysis. Now coming to the results. So this table shows the cohort characteristics of 100 individuals with SCN2A related disorders, and they have divided into early onset and the late onset group. Overall, 93% were alive at last review, and 61 were male. So the median age at the first assessment was about 4 years, and at last review was 5 years. And among the subgroups, the early onset group included 44 individuals, classified into benign, intermediate, and severe. And the late onset group had 48 individuals, further divided into those with autism or intellectual disability without epilepsy, then childhood onset epilepsy, and the mid-infancy onset epilepsy. Interestingly, the early onset benign subgroup had the earliest onset and best outcomes, while the late onset childhood forms subgroup tended to be older at the evaluation. And a family history of epilepsy or neurodevelopmental delay, that is disorder, was seen in about 15% of the cohort. So this table summarizes the genetic variant distribution in the SCN2A cohort, and most variants were missense. Missense mutation, about 69%, found exclusively in the early onset cases. And in contrast, the protein truncating variant, that is 23%, occurred mainly in the late onset subgroups, and 8 individuals had this 2q24.3 copy number variants. Now, regarding the inheritance, so most of the variants were de novo, that is 72%, with very few inherited from parent. So about a quarter had unknown inheritance, largely due to the missing parental data. So in summary, de novo missense variants defined the early onset severe phenotypes, while the truncating and the CNVs are linked to later onset or non-epileptic presentations. And this is the continuation of the previous table. So this here they highlights the epilepsy features across the SCN2A phenotypic subgroups. And overall, 83% of the cohort had epilepsy, and all early onset cases were affected. And the median age of seizure onset was sorry. So the overall 83% of the cohort had epilepsy, and all early onset cases were affected. And the median age of seizure onset was early, very early, that is around 1.4 months in the early onset group, compared to 10 to 32 months in the late onset cases, consistent with gain of function missense variants. And about half of all the individuals had active epilepsy within the past 3 months, while a quarter were seizure-free for over a year. And the early onset benign and intermediate subgroups showed better control, whereas the early onset severe and the late onset mid-infancy groups had persistent refractory seizure. So the median seizure offset age was meaning the seizure freedom for more than a year was around 5 to 8 years in early onset and 8 to 10 years or later in the late onset forms. So coming to the relation of epileptic spasms and anti-seizure medications used across the SCN2A subgroups. So overall, 25% of individuals had epileptic spasms, and most commonly in the late onset mid-infancy group, whereas 76% were affected. And in contrast, spasms were absent in the early onset benign and the intermediate phenotypes. So that was absent and seen only occasionally in the early onset severe cases. And nearly all individuals required multiple anti-seizure medications. So with a median of um, uh, 7 ASMs ever used, reflecting treatment-resistant nature of the SCN2A epilepsies. So most are currently maintained on 1 to 2 drugs, though the mid-infancy group often needs ongoing polytherapy. So in summary, epileptic spasms define the mid-infancy phenotype and polytherapy is the rule. And coming to the next table, so this table outlines the developmental and the functional characteristics across the SCN2A phenotype. So the overall 91% of individuals had developmental delay or intellectual disability, seen in all the late onset and the early onset cases, while the early onset benign subgroup showed normal development, showing a clear gradient of severity. And autism spectrum disorder was seen in about 29%, that is 29% overall, but much more common in the late onset subgroups, especially those with ID or ASD without epilepsy, compared to very few early onset cases. Now, developmental plateau or regression occurred in about 2/3 of cohort, and most often in the mid-infancy and the childhood onset groups, reflecting the impact of later seizure onset on the neurodevelopment. So, so this table summarizes the key developmental milestones across the SCN2A subgroup, focusing mainly on the motor and the language domains. So for the motor skills, about 62% could sit and 55% could walk independently. And these milestones were consistently achieved with the early onset benign and the intermediate cases, but were absent in the early onset severe individuals. And among the late onset subgroups, most with ID or ASD without epilepsy or childhood onset epilepsy achieved walking, while mid-infancy onset cases had poorer outcome. The language milestone showed a greater delay, that is only 31% spoke single words and less than 20% formed sentences. And speech was best preserved in the early onset benign and intermediate group, but minimal in the early onset severe and mid-infancy phenotype. And for receptive language, about half followed a single step command, and only 1/3 managed two-step commands, highlighting the severe communication and the comprehensive deficits in most of the affected group. So this figure showed how SCN2A related disorders can be divided into distinct phenotypic subgroup based on the motor and the expressive language milestones. On the left panel, that is on the left panel A represents the early onset phenotypes, where most individuals, especially severe and the intermediate cases, show limited milestone achievement. So many remain at the basic stages like babbling and cooing, and only a few progress to single words or standing, indicating global developmental delay and severe neurological impairment. And on the right, that is panel B, shows a late onset phenotype which display a broader developmental range. So many reached walking, running, and multi-word sentence, reflecting the milder and more variable outcomes typical of autism or later onset epilepsy. And here, this figure compares the age, motor development, and the language milestones across the early onset and the late onset SCN2A phenotypes. And in the top panel, that is A and B, we see early onset subgroups. And panel A shows gross motor milestones, where a clear severity gradient appears. And early onset severe cases show minimal progression, rarely beyond sitting. And early onset intermediate individual achieves standing or walking, and early onset benign cases approach near normal motor function, including running and hopping. And panel B mirrors, it shows the late onset phenotypes. And so the late onset phenotype, which generally show better developmental outcome. So most achieved higher motor skills like running and climbing. And in the language, they have attained many developed verbal communication also. So developmental milestone achievement varied between different CNV subgroups also. So the 5 individuals with deletions involving the SCN2A, 3A had relatively less severe motor than language milestone. Now, coming to the functional abilities in individuals with SCN2A related disorders. So this we have seen earlier, the 4 functional system. And on the left panel, we see early onset phenotypes divided into benign, intermediate, and the severe subgroup. Early onset benign group performs near normal across all the domains. And mostly they remained in level 1. And while the early onset intermediate group shows mild to moderate deficit, and in contrast, the early onset severe group falls predominantly in the level 4 or 5, indicating global functional impairment in the motor, communication, and the feeding abilities across the early onset severe phenotypes. And on the right panel, that is the late onset phenotypes show greater variability and generally better outcomes. And most with ID and AST without epilepsy and childhood onset epilepsy remained within levels 1 to 3, while mid-infancy onset displays a wider severity range, including some with more marked impairment. So this figure represents the Vinland Adaptive Behavioral Scale 3. Results assessing the adaptive function. And here we can see that panel A, that is on the left, we see the early onset and the late onset subgroups. And early onset benign individuals perform within normal limits across all the domains, but scores decline sharply through the early onset intermediate to early onset severe, where functioning falls well below the average. And among the late onset, so late onset group outcomes were more variable, but generally they were milder. And panel B shows subdomain details. And early onset benign cases maintain near normal communication and motor abilities, with early onset intermediate showed moderate deficit, and early onset severe exhibit a profound impairment. And so this figure summarizes the developmental and the adaptive functioning across the SCN2A phenotype. And here we can see that in the early onset group, outcome range from near normal in the benign cases with full mobility and speech to severe global impairment in the early onset severe subgroup. Among the late onset phenotypes, ability form a continuum, that is those with ID, ASD, without epilepsy retain the best motor and the communication skills, while the childhood and the mid-infancy onset epilepsy show a progressive lower adaptive scores and reduce independence. So coming to the discussion, so SCN2A related disorders show a broader phenotypic spectrum from mild to moderate forms. And in this cohort, the early onset phenotypes appear to form a distinct subgroup rather than a continuous severity spectrum. And the late onset subgroups are typically defined by the presence or the absence of epilepsy. And subgrouping by age of seizure onset revealed the functional outcome differences. That is, late onset mid-infancy phenotype had a lower motor function compared to the childhood and the ID or ASD without epilepsy groups. And the early onset severe individuals never achieved sitting, while the early onset intermediate could walk. So hence, it helped to reduce the clinical heterogeneity and aid in prognostication. And developmental delay was evident within first year of life in most individuals. And around 2/3 experienced at least one episode of developmental plateau or regression, usually before the age of 2 years. And the triggers were seizure onset or emergence of a new seizure type and anti-seizure medication change. And the severity and affected domains varied between the subgroups, and the communication impairment were the most severe across nearly all the subgroups. And only early onset benign and early onset intermediate subgroups showed limited expressive language. and the motor, eating, and the drinking skills were often relatively better preserved than the language. And in the coming to the functional classification observed, early onset severe subgroup had a median level of 4 to 5 with no independent function across the domains, and the late onset, the mid-infantile subgroup, the median level of functional classification was 3 to 4, that is limited independence across the domains. And in this cohort, the WAPS 3 findings parallel the developmental milestones and the functional classification system. And ABC scores were similar across the late onset phenotypes, despite the lower motor function in the mid-infantile group. So this may be because in the WAPS ABC score, they have excluded the motor domain data. So coming to the limitations, so the study lacked the functional characterization. So the analysis were based mainly on the phenotypic categories rather than the biophysical mechanism. And the retrospective data collected introduced a recall bias. And it had a limited age range. That is, the oldest participant was 21 years. So adult outcomes and the long-term trajectories remains unclear. And prognostication is also challenging, especially in the early onset phenotypes, because of the insufficient time to observe developmental trajectory, and the variant type and the biophysical severity do not reliably predict the outcome at the onset. So study had certain strengths. That is, it is a large, well-characterized cohort for a rare genetic disorder. And the systematic phenotype subgrouping allowed a reduction of clinical heterogeneity, and use of multiple standardized measures enhanced robustness of the functional outcome assessment. And findings aligned with the previous literature, and data offer a real-world prognostic value. And limitations were incomplete functional characterization, retrospective data, age limit, as well as early prognostication difficulty for early onset phenotype. So this study establishes a phenotype-based subgrouping as clinically meaningful for prognosis and functional stratification, and it supports the WAPS 3 as a practical outcome measure for SCN2A disorders, and it reinforces the need for prospective longitudinal data to track development and treatment response. So in conclusion, SCN2A is a broad developmental spectrum disorder ranging from typical outcome in early onset benign cases to profound impairment in the early onset severe and the mid-infancy onset phenotype. And distinct early onset phenotype, that is, they have divided into benign, intermediate, and severe form confirms a meaningful categories, and the late onset phenotypes form a continuum of severity. And developmental regression were common, often associated with the seizure onset and the anti-seizure medication change. So the phenotypic subgrouping aids prognosis and inform the clinical trial design. Communication and adaptive behavior represents the key measurable outcomes for future therapeutic trials. And this study highlights urgent need for targeted therapies beyond self-limited neonatal phenotypes. Thank you.
Can you summarize the what you have somebody asked you regarding SCN2A?
So,
include the brain
yes. So
there should be some take home.
Yes. So summarizing the SCN2A related disorders, so they have a phenotypic and genotypic heterogeneity, and they can be grouped into early onset, late onset epilepsy, and late onset epilepsy with ID or ASD without seizures.
This is the best one. 2017 is the best one from
Yes.
a treatment point of view.
Yes, sir.
2017 has clearly told you where which drug will work.
Yes.
So let's talk about that.
So in early onset epilepsy, that is less than 3 months, where gain of function, which occurs, and that is missense gain of function occurs. So there is increased sodium channel activity. Hence, the response to sodium channel blockers. So they will respond to, they shows a good response to sodium channel blockers.
That first point. So SCN2A, early onset, less than 3 months, has a gain of function. And they respond very well to sodium channel blocker. High dose of sodium. This is almost similar to which other subtype of sodium channel calcium. Anyone?
SCN 8A.
8A. So 8A also has got this kind of a gain of function. But now we know that SCN 8A can also have a loss of function. Now, beyond 3 months, this exquisite sensitivity to sodium channel is lost. Why?
Yes. Because that mainly occurs because of the loss of function, truncations and the. Yes.
So here it is actually loss of function. So this was the first hypothesis, and this holds true for most of the things. From a phenotypic point of view, if you look at the seeds of SCN2A to the SCN1A, how do you differentiate?
So SCN2A mainly presents as a like broader spectrum will be there. It can be benign or it can be like.
That's a great thing is if you have tonic station, like autoharrison is basically tonic phenotype. The tonic phenotype is a part and parcel of SCN2, whereas SCN1A has generalized clonic station or clonic station. So that phenotypic variation is something we need to pick up. Okay. So that's the difference between SCN1A versus SCN2A. Okay. Now coming to our article, this current article.
So our article, so they have studied the development and the adaptive function in individuals with SCN2A related disorders, and they have broadly divided. So
overall outcome of SCN2A, is it good, bad, or good?
So that is that can be based on the phenotype.
Okay, so what gives you a good outcome? About 1/3 had a good outcome.
Yes.
Which subtype had the good outcome?
So early onset benign subtype.
Correct. Early onset benign subtype had the good outcome. Actually, 90% of them had a very good outcome. Whereas early onset intermediate had a higher outcome, but rest all had poor outcome.
Yes.
Are you getting me?
Yes.
So even if without seizures, the autism spectrum subtypes, as well as the language repression subtypes, have bad outcome.
Yes.
Okay. So that is something. So what do you mean by this copy number variation?
Copy number variance. So that means they include the other SCN gene also. That is
so because these
other
are
than
quite linked together,
yes.
very close together. So chunky deletions can not only affect 2A, but they can also affect
1A and
3A. 1A and 3A, which are adjacent to each other.
Yes.
So they can also get affected in the deletion. So they can also have a bad outcome.
Yes.
So that is the take home. Okay.
Okay.
My next topic for the today's journal topic would be on GLP-1 receptor agonist in IH. Myself, Dr. Rohith, under the guidance of Dr. Soumya Madam, I am presenting this journal for today, which was published in JAMA Neurology in 2025. So as an introduction to this topic, we all know idiopathic intracranial hypertension is a condition where there is raised ICP due to no established reasons. So the symptoms most commonly would be headache, visual obscurations, pulsatile tinnitus, and back pain and dizziness. And the diagnostic criteria includes the patient should have papilledema, suggesting of raised ICP, normal neurological examination except the sixth cranial nerve being affected because of the raised ICP, and neuroimaging supporting our raised ICP findings, normal CSF and elevated lumbar puncture pressure, that is more than 25. And there can be presentations where there is without papilledema. However, there should be other criteria which are meeting the raised ICP, and headache attributed to IH will have a specific criteria where the patients will have in relation to that of the The headache would be a new onset headache in relation to that of the raised ICP pressure, which we are documenting. And on reducing the ICP, there will be a reduction in the headache, and there can be an exacerbation in response to any associated causal factors, which I'll be describing in further slides with respect to IH. And IH, we all know, although there is no established reasons, the CSF dynamics is likely to be a result of any ongoing insult or initial trigger which is causing overproduction or under drainage leading to the raised ICP. And this occurs as frequent as 1 case per 100,000 population per year, and it can increase to 19.3 in obese women who is in a reproductive age group between 20 to 44. And there are well-known associations which I was mentioning earlier, that is female sex obesity, rapid weight gain, PCOS, which can lead to this. And there is increased trend noted in the incidence of IH, which is going in the trends of obesity, where increased obesity trends lead to the increased incidence of IH. And weight loss eventually has shown good result in the clinical improvement in several parameters, not only reducing the ICP, papilledema, and headache, also the well-being of the patient. So the pathophysiology, as I was telling, includes the hypersecretion of CSF, outflow obstruction, and increased venous sinuses pressure, and that is mainly by 3 mechanisms. And on concentrating mainly about the obesity here, the obesity which is causing IH is mainly because of postulated mechanisms telling obesity can increase the intra-abdominal pressure and further the intrathoracic and in turn the intracranial pressure. And the role of 11-beta hydroxysteroid dehydrogenase 1, which is present in the adipocytes, which can get upregulated in the mature adipocytes, which is also present in the choroid plexus. The main function of this hydroxysteroid dehydrogenase is to convert the cortisone into the cortisol. So when this is getting upregulated, there is an increased local cortisol production, which drives the sodium and as well as the water inside, and thus increases the CSF production. Apart from this, we all know that central obesity leads to increases the inflammatory state in the body, that is a chronic inflammation, which leads to the effect on or the upregulation of the 11-beta hydroxysteroid, leading to this features of increased CSF and then the IH. So the therapeutic strategy in IH includes not only it includes mainly the reduction of the pressure in the by reducing the CSF production. Not only that, it has also shown that there is lifestyle and behavioral interventions by reducing the weight. A study has found that there was with a BMI of more than 40 were likely to have severe papilledema when compared to, and every 10 kg increases the odds of severe visual loss. So weight reduction between 3 to 15% in within 6 months have shown to have achieved the disease remission in many studies. And not only within 6 months, and there should be a sustained weight loss which has attained to prevent the relapse and to modify the disease course. So the lifestyle recommendations as given in 2023 guidelines includes mainly the physical activity, diet, and the behavior. And in pharmacotherapy, it includes acetazolamide, which reduces the the intracranial pressure. However, our concentration here is on the GLP-1 receptor analogs, which is very important for the weight management, which has been upcoming in the last few years, that is last 5 years. And also the bariatric surgery, emphasizing that the weight loss also plays an important role in bringing down the intracranial pressure. And specifically on the GLP-1 receptor agonist, it acts through various mechanisms of P1, PI3K, and CAMP, which can increase the beta cell proliferation and neogenesis and increase the insulin gene expression, and thus affecting the sensitivity over various tissues, including adipocytes, liver, and the muscle. Not only that, it also acts in the brain by reducing the appetite, increasing the satiety, and increasing the energy expenditure. And we can see here GLP-1 receptors are being expressed in the choroid plexus, where on getting expressed in the choroid plexus, it reduces the CSF production and thus reduces the ICP. So the available GLP-1 receptor analogs are characterized based on many things. There are short-acting, long-acting GLP-1 analogs, semaglutide, liraglutide, lixisenatide, exenatide, and dulaglutide. And there are various adverse effects or very minimal adverse effects like GI reactions, nausea, and vomiting. It is usually well tolerated, and the rare or the significant severe adverse reactions are very rare, and it helps in majorly helping in reducing the weight and also reducing the sugars, that is lowering the blood glucose and down regulating the inflammatory response and improving the blood pressure. With this introduction, we'll go into the journal where it aimed to evaluate the impact of these receptor analogs on IH management, focusing on the medication use, symptom or the sign burden, and procedural intervention using a large national data set, which was a retrospective study mainly by the TriNet US Collaborative Network. They collected the information on March 3rd of 2025 from which included 67 healthcare organizations in US. The inclusion criteria was adults who had IH between 2005 January 1st to 2024 April 1st with more than 1 year of follow-up. And exclusion was before the onset, whether they were on GLP-1 receptor, that were excluded, and other secondary causes like hydrocephalus, venous sinus thrombosis, malignancy, and hypertensive encephalopathy were excluded. And they screened around 44,373 patients. After propensity score matching, that is when they matched the control groups, they divided basically into the receptor analog group and in the control group. So the control group consisted of patients who had the conventional drugs managed with valproate, tricyclic, topiramate, acetazolamide, metazolamide, and dietary counseling and surveillance. And the other group was a GLP-1 receptor group. They did not mention the drugs which were taken. However, the group included lixisenatide, albiglutide, dulaglutide, semaglutide, liraglutide, and exenatide. And after propensity score matching, that is which was used to remove the confounding factors, it was the numbers were 555 in each group. And outcomes were assessed up from 1 day to 1 year after the index event of starting or initiating the GLP-1 receptor analog. So the propensity score, which I was telling, was mainly to it was a statistical technique which was used to reduce the confounding factors, and there was a logistic regression analysis which was used to match this one, where they use this algorithm, 1:1 matching algorithm with age, ethnicity, overweight, obesity, diabetes, behavior and neurodevelopmental disorders, etc. And also the baseline medication used, the metazolamide, furosemide, topiramate, TCS, valproate, oral hypoglycemics, and baseline DMAs to match the group. And the statistics and the statistical analysis were the sensitivity subgroup analysis were performed into BMI of 40 or greater and less than 40, and further analysis were compared between the GLP-1 receptor analogs with of the to the bariatric surgery and those to that of the conventional management. So coming to the results, the baseline characteristics of GLP of this study was, among the GLP-1 analogs, the age at the index was around 42 in each group, 42.7 and 42.5 respectively, and we can see there was a higher female gender preponderance of 86.1% in each group, and most of them were whites, that is around 54% were in whites, as it was a US conducted study, and 65, that is the 361 patients were overweight and obese, and and there were 34% of patients who had dyslipidemia and 42 hypertension, 30 of them had diabetes. Further characterizing them, the baseline characteristics, again, most common symptoms were headache, visual disturbances, and dizziness. Papilledema was noted in 70 patients in each group. And baseline medications which they were on were acetazolamide commonly, and followed by topiramate, and then followed by the oral hypoglycemics and the valproate, oral hypoglycemics, valproate, and the tricyclic antidepressants. And baseline procedures conducted were slightly higher in the control group, that is by 40 patients underwent a bariatric surgery procedure, and as well as other acutely to relieve the pressure, they underwent a CSF shunt procedures more in the GLP-1 receptor group. And coming to the BMI, around both the groups at the baseline. At the baseline, it was in both the groups, they took 25, average of 25.2 percentage in both groups. And the baseline BMI was 41.8 and 41 in each groups. So with this, the outcome was measured at 1 year. As we can see, in the GLP-1 receptor analog group, the use of any medication reduced drastically when compared to that of the control group, where it reduced by around 165, around 30% were only on the any medication with respect to the GLP-1 on those who were taking GLP-1 receptor when compared to the control group. Acetazolamide use was reduced to around 48, the 8.6% when compared to the 24% in the control group. And the symptoms about the headache had reduced by which were all significant by 12.3% when compared to the 27.4% in the control as well as the GLP-1 receptor group. And we can see any procedure, that is at the end of 1 year, patients undergoing any procedure was higher in that of the control group and compared to that of the GLP-1 receptor analog group, which included either bariatric surgery or the shunt procedures. And due to reasons which was not mentioned, there was slightly higher mortality in that of the control group and compared to slightly higher mortality in that of the control group as that of the GLP-1 receptor analog group. And the BMI, important was the BMI change. There was not much of change in that of the BMI when compared to that of the control group with respect to that of GLP-1 receptor group. Even though the BMI was not reduced, the effect on reducing the pressure was the emphasis which was made in this journal. Mortality, they have not mentioned it, not get the supplement material. Sorry, madam. Yeah. IH without papilledema is 30% is without. In here, in the present study, it is only 12.6% in either group who had papilledema. That is a baseline thing. However, that was before, after matching. Before matching, it was around 30% who had papilledema. No, this is at the baseline. After correction, it was this. After correction, it was 2.2 in the GLP-1 receptor to 11.5 in the control group. So the forest plot analysis here also showed that at the outcome at the 1 year favored GLP-1 receptor analogs, except in the any medication that is the valproate use, or except that subtype that medication. Every others parameters like any medication use or visual disturbances and the papilledema reduction, those people who are undergoing procedure and shunt procedures were lesser in that of the GLP-1 receptor analogs when compared to that of the controls. And the subgroup analysis also showed that those who underwent, when compared to those who underwent bariatric surgeries, the group which received the drugs were associated with a lower medication use and a fewer symptom sign, even though the BMI in the surgery group, the reduction of the BMI in the surgery group was higher when compared to that of the GLP-1 receptor. And as well, that is, however, conversely, among the people who are not using the GLP-1 receptor analogs, bariatric surgery helped in reducing the symptoms, emphasizing that weight loss is a important parameter which has to be concentrated, but it required more procedures and had a higher mortality. So, taken from this slide was bariatric surgery achieved most weight loss. However, the receptor analogs provided a better outcome by reducing the symptoms, signs, medication use, and also the reducing the side effects of the surgery. So, with this, moving on to the discussion, first point was to emphasize on the weight loss. So, even the IIH weight trial, which was conducted as a randomized control trial, showed that the bariatric surgery, when compared to the community weight management guideline, showed significant reduction in that of the ICP change when compared to that of the conventional weight guidelines. So that tells that reduction of the weight or the first strategy along with the medication, meaning the reduction of the CSF pressure, should be the weight loss as well. And coming to the next trial, that is the IH hypertension pressure trial, which showed that here they evaluated the effect of GLP-1 receptor signaling on the intracranial pressure in people with the idiopathic intracranial hypertension. And it was a randomized phase 2 placebo-controlled double-mass trial, which recruited 16 patients. And there was a 1:1 randomization which was done, and they used subcutaneous exenatide. So exenatide was given and 8 patients, and exenatide was given in 7 patients, and compared to that of the placebo in 8 patients. And they looked at the ICP change at 2.5 hours, 24 hours, and the 12 weeks. And at the 2.5 hours also, that is acutely, there was a reduction in the ICP pressure to 21.8, which remained 26 in the placebo, and which was sustained at 12 weeks, that is when compared to that of the control, which was again sustained at 24 hours and 12 weeks. So and also secondary outcomes as in change in the monthly headaches and change in the BMI was change in the monthly headache days were significantly high in that of the exenatide subgroup when compared to that of the controls. So this was a phase 2 trial which was published in Brain Journal in 2023. However, the study had its limitations, which was because of the short-acting nature of the exenatide and side effects that all the patients in the exenatide arm had nausea, and it was a small trial consisting of only 8 patients. So further, there was one more study which had 39 patients, which was an open label single center study, which was a case control study where they used as an intervention of with semaglutide, liraglutide, and comparing with that of the usual weight care management. And their primary endpoint was to see the weight loss at month 6 compared to that of the baseline. So they saw that there was a significant high mean weight loss, which was of reduction to 12% when compared to that of the control group. And it was more common in the GLP-1 receptor. And also there was a significant reduction in the medication usage, that is acetazolamide usage, and the mean headache days were reduced when compared to that of the control group. So all of this was telling that the use of GLP-1 receptor analogs help in reducing the weight, not only weight, also reduces the intracranial pressure by various mechanisms. As I was telling before, it is expressed in the choroid plexus, and it reduces the sodium potassium ATPase activity and further reducing the CSF production. And not only that, it also helps in it increases the satiety also, and by reducing, and also by further reducing the appetite, as it acts in the hypothalamus and also in the nucleus tractus solitarius. So the message from this was GLP-1 was effective and safe treatment in achieving significant weight loss. So the limitations of the study were many. One was the assessment was done only by the database, which was by the Trinitex US program, and it included only the healthcare organizations of the USA, so it cannot be applied for the international population. Second was they were unblinded. The people were aware of the GLP-1 receptor analog therapy, which may have influenced the symptom by the expectation bias and assumption of medication use. They didn't have the prescription which was followed up. They didn't look into the adherence, and just the prescription implied that it was they were using and adhere to the therapy, which might not reflect the real world compliance because of the side effects of the GI side effects of the drug. And there was no data on the drug type, dosage, or the route which was administered, so which could not differentiate the different analogs or the different dosages pattern and the administration routes, which can limit our pharmacological effects of these drugs. So based on this one, the critical appraisal for this was it was a retrospective study with a very large population, and they also used scores to remove the confounding factors, and they had a relevant and a clinically meaningful outcome measures which were tested, and the impact of this was very much important because there were data which was telling that the medication use can reduce the surgery at the end of 1 year, which was seen in this study. And the future need was a prospective control trials are needed for defining the dosage, the duration, and the long-term outcomes of this drug. So as a take-home message, I would tell there are the management of IH definitely includes immediate reduction of the pressure by either traditional drugs, that is acetazolamide, topiramate, and furosemide, or in a patient who are having fulminant IH with a visual impairment being a significant factor where we can consider surgical intervention. However, the newer targeted drugs, that is the GLP-1 receptor agonist and the upcoming 11-beta hydroxysteroid dehydrogenase 1 inhibitor, has to be considered along with the conventional therapy, that is by dietary intervention, exercise intervention, and the cognitive behavioral intervention, where the patient achieves a better weight loss. And thus will be able to achieve the reduction in the pressure and also the maintenance of the and avoiding the relapses in the IH. Thank you. Sorry, madam. Cost. Headache. I couldn't find the headaches. Headache. Regarding that, there was one data where the removal of the after the 3 months when they had taken the therapy, there was rebounding of the headache which was seen. I couldn't find this. It was a clinical diagnosis which they had. They took few say clinical symptoms, and it was mainly based on the prescription based. Whether the prescription had the diagnosis as IH and they were given GLP-1 receptor analogs was the thing. No, it was only prescription based, which was extracted from the TriNet collaborative network. That was one of the limits. Based on the physician clinical assessment at that point of time, they had taken the diagnosis as IH. They had not further looked into the imaging or the clinical parameters. They had not established that. It was only based on the physician assessment at that point of time. That was one of the limitations. First, no, it was two things at the onset and as well as at the end of 1 year, which they had seen. It was. They had looked into the medication use, the symptoms, and as well as the procedures they underwent. 3 groups they had seen. Whether they had a patient had a reduction in the symptoms, reduction in the medication use, and did they undergo any surgery in between or not. Not just this article, and there was various trials also which showed usage of GLP-1 receptor analogs to reduce the. It helps in not only reducing the weight, also reduces the intracranial pressure. Definitely, using this in a clinical practice would help in managing the weight reduction and as well as reducing the intracranial pressure. There are studies where they showed the short-acting drugs like exenatide had immediate intracranial pressure reduction. Not only that is that IH pressure trial which saw that the immediate pressure reduction which was seen. 1 year. By 2 routes we have, but currently in India it is oral. There are subcutaneous weekly dosages and monthly dosages which are available as well. Ribelsis is the semaglutide brand which is available. 3721 40 3714 is
Actually, so 37 and 40 all have the same cost. So you can either buy the 14 and ask them to take half challenge or something like that, or you can start with 3. But the main problem is there's something out of the headache is almost giving a migraine like headache. You initiate this is something you need to give back. Like almost 20 to 25% may drop out of this therapy because of this new onset headache when you start the hydration is very important to reduce it. If you are dehydrated, the risk of semaglutide induced fatigue worsens. The next thing is excessive belching and discomfort at the lower the esophageal. So the efficacy can they have as if something is sitting there. So that is something which is very common when you start semaglutide, and many may drop out. So these are the 2 very common side effects which I have encountered after private societies they are available.
Thank you all. That was for today.